Hi there, my name is Lindsay Ferguson. I'm one of the Gynecologic Oncology Fellows at University Hospital Simon Cancer Center. I wanted to say thank you for allowing me to present our pilot study entitled Using Exhaled Carbon Monoxide as the Fifth Vital Sign in an Outpatient Oncology Clinic. This is, like I said, a pilot study looking at the impact on provider and patient engagement in smoking cessation efforts. I have no disclosures today. Here's a look at our objectives for my talk. A little bit of background information. So cigarette smoking has a causal relationship with cancers of the lung, larynx, oral cavity, pharynx, esophagus, pancreas, bladder, kidney, cervix, stomach, as well as AML. We know that continued tobacco use in cancer patients is associated with poor therapeutic outcomes, including increased surgical and radiation treatment toxicities, increased risk of secondary malignancies, decreased treatment efficacy, and increased mortality. Smoking cessation is a particularly cost-effective intervention that is significantly underutilized in oncology practices. Often, clinicians will cite the lack of training in cessation interventions and patients' resistance to treatment as barriers to providing this cost-effective intervention. Smoking cessation intervention in the context of biologic feedback of smoking is associated with greater success. And this has been studied in populations like lung cancer and doing lung cancer screenings, etc. The measurement of exhaled carbon monoxide provides an immediate, non-invasive method of objectively assessing smoking status that may duly serve to incentivize and provide feedback to patients and providers in an oncology clinic setting. In our study, we sought to evaluate whether routinely incorporating exhaled carbon monoxide measurements as a fifth vital sign in an outpatient setting would result in greater patient and provider engagement in smoking cessation efforts. For the methods of our study was a nested cohort study looking at smokers that were identified amongst gynecologic oncology patients at the various university hospitals' clinical sites. Our intervention group was at the Westlake site, and this was compared to all the other University Hospitals Gynecologic Oncology Clinic patients. Smokers were identified prior to patient visits, and at the intervention site, these patients were then provided an exhaled carbon monoxide measurement during collection of their routine vital signs. This information was input into the EMR, and the providers were able to view what the exhaled carbon monoxide measurement was. We then compared the tobacco cessation referral patterns between the study site and all the other gynecologic oncology clinics within our network. At university hospitals specifically, there's a tobacco intervention and psychosocial support program, also known as the TIPS program, and this was the site that we looked to see if referral patterns were increased. This is a look at the two different cohorts of patients that we had in our study. Cohort 1 was the intervention site, also known as Westlake Gynecologic Oncology Clinic, and cohort 2 was all the other gynecologic oncology clinics within our network. Within both cohorts, we looked at the documented smokers, those that were diagnosed with cervical cancer, cervical dysplasia, vulvar cancer, and vulvar dysplasia, as these are smoking-related cancers. Within cohort 1, our intervention site, there were 20 patients that were identified during the study period. And within cohort 2, there were 51 patients that were identified during the study period. Here's a look at our results. During the study period, a total of 328 patients were identified with cervical cancer, cervical dysplasia, vulvar cancer, or vulvar dysplasia using ICD-10 codes. And these were amongst the 7 different gynecologic oncology clinical sites between May 1st and August 31st of 2019. Of these 328 patients, 71 were documented smokers. In the figure 1, you can see the age ranges of our patients, and that was anywhere between 22 and 90 years old. Patients between the age ranges of 50 to 59 were the largest subset of our patient population. And this is of the 328 patients total. Of those that were, of the 328 patients, 22% of them were smokers and 78% were not. Of the smoking patients, you can see there's a pretty wide distribution amongst the age ranges. Again, the largest patient population or age range for the smoking patients was between 50 and 59 years of age. We then compared the TIPS referrals across the various clinical sites. Westlake, being our intervention site, is shown up at the top with 9 patients referred to the TIPS program, and all the other clinical sites were listed below. There was a significant difference between the TIPS referrals at the Westlake program compared to all the other clinical sites. In this graphic, you can see the exhaled carbon monoxide levels between those patients who were referred to the TIPS program and those who were not. A normal exhaled carbon monoxide level is less than 5 generally, and as more tobacco is used, that level will go up for patients. Those patients that were referred to the TIPS program appeared to have higher levels of exhaled carbon monoxide than those that were not. However, the numbers of patients who actually received exhaled carbon monoxide testing was overall low between all sites, including the intervention site. In conclusion, the incorporation of routine carbon monoxide measurement in an outpatient gynecologic oncology clinic appeared to be associated with increased engagement in smoking cessation efforts by both the patient and provider, and this was determined by looking at the referrals to the TIPS program. In future projects, we hope to increase the uptake of the exhaled carbon monoxide measurement amongst all the university hospitals, gynecologic oncology clinical sites, and not just the intervention site, and to be able to look at whether or not routine carbon monoxide measurement is associated with greater long-term engagement and success in cessation programs such as TIPS. We also would like to be able to analyze the cost effectiveness of exhaled carbon monoxide measurements for patients with a gynecologic malignancy. I would like to thank several people who worked on this project, both Sanjana and Michaela, our medical students, Dr. Monica Webb-Hooper, who runs the TIPS program, and Dr. Christine Zanatti. In addition, obviously, all of our patients and our clinical staff that was involved in collecting the exhaled carbon monoxide levels. Here are my references. Thank you very much for the chance to speak.